I'm the ICU director at San Gorgonio Memorial Hospital, so I'm in charge of the intensive care services. I've been with Beaver Medical Group as the pulmonologist, critical care specialist, and sleep specialist since 2007. I'm an assistant professor at Loma Linda University, and I'm also an assistant professor over at UCR School of Medicine. Anyway, let's talk about sleep disorders. Got sleep? Some of you don't. Let's talk about why you might not be able to have sleep. But before we begin, in earnest, I want to tell you that this is what I'm going to talk about today may not affect all of you the same way, okay? So you can't take exactly what I say. In other words, don't try this at home. And for that, I give you a slide of somebody taking a picture here. And when he's done taking his picture, he is going to come back onto the rock. Notice he's wearing just some sandals there. He's got his picture. That's kind of the mid-air picture. I don't know how many feet are down below. But he manages to hold on with one hand, and the camera equipment is still there. So that shot is worth a lot. There's an easier way of doing things. Okay, so if you go to the Grand Canyon, if you haven't done this, I recommend doing it. And you can go on the skywalk, which is a horseshoe that goes over the floor of the Grand Canyon. It's much safer, and you can just look right down. Unless, of course, you're afraid of heights, then maybe you shouldn't do that. So do you notice anything about these pictures? Snoring, okay. What else do you notice? Bothering the other person. But I noticed something else about this. The man is sleeping on this side of the bed and the woman is on this side of the bed. Do you notice that? There's only one example where that is the opposite, and that's here. How many people, I just want a show of hands, this is a very unscientific survey. How many sleep in this configuration with the man to the right of the woman? Raise your hand. Okay, how many is it the opposite way? Okay, that's pretty interesting. That's about half and half. And yet, I remember my parents would sleep in this way, and my family sleep this way. And anyway, I never knew why that was. But they did a study. They did a study, and they find that this seems to be more common, although not here in this population. It seems to be pretty split evenly, interestingly. My partner, Dick Sheldon, who some of you may have known, or he used to work out here, he said that he moved in several houses, and he used to be on call, and the thing that determined which side of the bed he slept on was which side the phone jack was on, because he was the one that was on call, not his wife. So he would sleep on the side of the bed with the phone jack. Of course, now that doesn't matter anymore, right? We don't need a phone jack. The theory seems to be that this goes back to medieval days, where the man would have to, at the beck and call in the middle of the night, grab his sword to protect his woman. It's so romantic, isn't it? Nevertheless, let's talk about sleep changes today with normal aging. Okay, insomnia, obstructive sleep apnea, restless leg syndrome, medications, and then narcolepsy. Narcolepsy is, I'm sure, something that you don't have, but I'll let you know what it is because you've heard that term before. So let's get into this a little bit. Let's talk about sleep changes with normal aging, okay, or normal sleep changes with aging. So there are different stages of sleep. Sleep is not an on-off phenomenon. You may know that, right? Sometimes you can sleep well, sometimes you can sleep not so well. The New York guy who gets up in the middle of the night, the wife says, "How'd you sleep last night?" And the guy says, "I made some mistakes." So didn't sleep very well. But you can see here that we start at zero, stage 0, and there is a progression of sleep that occurs. And finally, you go into this thing called REM sleep. Does anyone know what REM sleep is? REM sleep, it stands for rapid eye movement. What is it? It's a deeper sleep. It's a sleep typically where you become paralyzed. That's important because if you have a problem with sleep apnea and your airway is weak, it's collapsible, and you can't get air in because of that, if you become paralyzed, any kind of muscular compensation for that is going to be absent. And so it's very possible that people get worse sleep apnea during REM sleep. And as you can see, as the night progresses, the REM periods become longer and longer. How many would say, do you remember dreaming? Okay? Sometimes you remember dreaming. Is it usually at the end of the night that you have your dreams, or at the beginning of the night? It's at the end of the night, that's correct. And this makes sense because REM sleep is more frequent and it is longer at the end of the night. Okay? It is a mentally restorative sleep. Stage 3 and 4, which is here, is a more physically restorative sleep. This is where growth hormone is released. Little kids who are like, 4, 5, 6 years old, all they do is 3 and 4 in REM sleep. That's all they do. They're either getting growth hormone, which makes them feel great, and it makes them grow, or they're getting REM sleep, which means they're dreaming. And that's really what makes you feel so good when you get up in the morning, is this physically and mentally restorative sleep. Well, guess what happens when you get older? This stuff goes away, and this is what you're left with. Okay? And you can probably attest to that, right? And most of those changes occur, guess what decade? 40s and 50s. I'm going through that right now, okay? My wife has not had a good night of sleep ever since we had kids. And there's probably for multiple reasons. So here's another representation of sleep stages. Again, awake, you go down, you go into this REM sleep, which is actually high up on the graph, but is actually very good. And as you get older and older, you can see that you have more arousals, more awakenings, less REM sleep, and less deep sleep. Do you see the stage 4 down here? It's absent. So this is what's going on with sleep. This is normal. This is what happens. So most of these changes occur by the age of 40 or 50. Sleep remains pretty constant from age 60 to 90, okay? Generally speaking, except sleep efficiency. What is sleep efficiency? That means if I take the number of hours that you're asleep and I divide it by the number of hours that you're in bed. Okay, that's sleep efficiency. One is the numerator, the other is the denominator. That is sleep efficiency. That does decline somewhat from 95% to 80%. By middle-aged, you have increased awakenings, arousals, and stage shifts. Do you know what a stage shift is? You have this circadian rhythm that's built into your body. And it tells you when to go to bed and when to wake up. Now, part of that is also how your day is. You can have an exhausting day, and that will drive you to go to bed more quickly at night, correct? Okay, so you can feel that. Well, as you get older, what happens is instead of waking up at 6 o'clock, you're now waking up at 5 o'clock or even 4 o'clock, okay? And instead of going to bed at 10 or 11 o'clock at night, you're like, I'm checking in at 8 or 9, okay? So what happens here is your sleep stage is shifting earlier. You're not only going to bed earlier, but you're getting up earlier. That is a circadian rhythm shift. That's going earlier. Do you know what type of people have it in the other direction? It's the reason why we don't let anybody in here that's less than, 55, right? So teenagers have the opposite shift. They have a circadian rhythm shift that goes in the opposite direction. They would rather go to bed at 12 o'clock at night or 1 o'clock in the morning, but try getting them up at 7, right? It doesn't work. They would rather get up at 8 or 9 o'clock. And this is something that we've known in sleep medicine for a number of years. So the question is why do we start high school at 7 o'clock in the morning or at 7:30? Does anyone know the answer to that? There is a reason why we start them at 7:30, even though we know they're not going to perform very well in those first 2 hours of school. And it's a little bit of a political problem, okay? It's because of after-school sports. You cannot have after-school sports if you have kids starting at 9 o'clock in the morning, because they'll go till 5. And if you don't have after-school sports, you don't have college sports. And there's a lot of money there, isn't there? So that's more important. Anyway, I've got off my soapbox. We know that teenagers shift back, and as you get older, you shift earlier, okay? We also know that your stage 3 and 4 sleep is going to get less. So don't worry. Now, we know that growth hormone, which is a hormone secreted from the brain, is secreted during this stage, as I mentioned. So they felt that maybe if they could just, even though people were not getting stage 3 and 4 sleep, maybe if we just injected them with growth hormone, they would feel better. And so they would take cows' brains, the pituitary, which is where this is synthesized, and they would grind it up, and they would extract it, and then they would inject it into people. And people felt better, they didn't sleep better. The problem was that they were grinding up cows' brains. Does anyone see a problem with that? Exactly. There were a few cases of mad cow's disease that were associated with injection of growth hormone. So I would not advise that. Phase advancement, we've already talked about that. And resistance to sleepiness. This is very interesting. This is actually a very interesting statement. Resistance to sleepiness and sleep deprivation. So here's the point. What this means is that I could take a middle-aged or an adolescent and deprive them of as much sleep as someone who is elderly. And who's going to have less of a decline in function? Who's going to be able to function proportionately better in that circumstance? The answer is the elderly patient is going to do better. They are better able to mask the effects of sleep deprivation. That's a good thing, but it's also a bad thing, because if you're looking for symptoms of sleep deprivation, you may not see it in an elderly patient. I feel fine, I've been doing fine. Okay? All right. Here's a Calvin and Hobbes cartoon about circadian rhythm. His mom is trying to wake him up in the morning. No, 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 I need more sleep. And then he's in school. I can't keep my eyes open. Then he's going up to bed. Bed already? But I'm wide awake. So here he is in bed saying, my internal clock is on Tokyo time. And that's exactly what the circadian rhythm issue is. It's giving you cues about when to go to bed and when to get up. And we'll talk about that a little bit later. Actually, we'll talk about it again here too. So this is a look inside of your brain about how and when to go to bed. There are two processes. There's something called process H and process C. And these are two vectors, if you will. Remember physics? You have two vectors, and you add up the two vectors, and the resultant is the resultant vector. So if you have a tug of war, if one vector is going in one direction and the other vector is going in the other direction, nothing's going to move, right? So this is what's going on. This is very easy to understand. This is just basically, if you're hungry, you eat. And after you eat, you're no longer hungry. So there's a substance in your body called adenosine. And when you get up in the morning at 9 o'clock, you have very little adenosine circulating in your brain because you've revived yourself. You've had a nice sleep. As the day goes on, however, depending on how your day is, if you're relaxing at Sun Lakes or if you're going out to the LA County Fair, you could have very different amounts. So the more you do, the more tired you become, the higher the adenosine levels become. And then you go to bed, and after you go to bed, your body reduces your adenosine levels back to zero. Sounds pretty clear, right? Easy to understand. It's homeostasis. Here's the part here that's a little interesting. This is called the circadian rhythm. This is going on internally in your brain. And you can't really change the amplitude, but what you can change is how it's shifted. This is the problem where you travel to Boston or to England or Europe. It's called jet lag. It's because your body is still on Los Angeles time, even though you're in New York or in London. And it's because this hasn't figured it out. So there are things that can shift this, like light exposure to your eye and melatonin secretion. And if these things are lined up perfectly so that this lines up with this is the kind of alertness level that you get as a result of that vector. Higher means more towards awake, and lower means more towards sleep. Let me show you what the perfect thing is here. When the highest amount to sleep corresponds with the drop-off in alertness, that's when you go to sleep. And that's what you need to really be able to go to sleep. You walk into the bedroom, my day is done, it's time for me to go to bed, and you're out. You can see here very clearly that if this is shifted and you try to go to bed when it's not time to go to bed, you're not going to go to bed. And we'll talk about what the problem with that is and how that can cause sleep problems. More than just sleep apnea. I'll tell you, sleep is so interesting. When I was in residency, I thought it was boring. But the more I learned, the more I found it interesting. And I found that before I went into sleep medicine, the journals for sleep medicine were boring. But it's amazing how much more interesting those journals became after I was done with sleep medicine. Sleep medicine is a lot more than just obstructions and sleep apnea. There is so much that we need to know. So the bottom line for normal aging is you go to sleep earlier and wake up earlier, and you have less sleep efficiency. So what we found is, in terms of shifting this, is that there are two areas that we can actually manipulate. These little symbols down here actually are ways that we can measure where we are in the circadian rhythm. This triangle here represents your lowest body temperature. I won't tell you what we do to college students to measure this temperature. We put a little thing up the bottom, okay? And we can continuously measure this. We pay them, but we can measure where the lowest body temperature is, and it's always right here. So we know, if we can map out where their body temperature is, we know where their circadian rhythm is. This little thing right here is much easier. We just take a little saliva sample and we can measure how much melatonin there is. So we know when we see this thing appearing that their alerting signal is ready to go down, and when we see this, we know it's ready to come back up again. So we'll talk about that later. I throw that in because we'll talk about that as it comes to obstructive sleep apnea and insomnia specifically. So insomnia increases with age, and in older adults especially. If you look at what they report, both initiating and maintaining sleep, 43% of them have a problem with that. What are the common factors associated with insomnia? There's a lot. I mean, medical illnesses. If you have to get up to pee 6 times a night, even though you don't have sleep apnea, and even though you don't have insomnia, you're going to have a problem with sleep. Psychiatric illness. This is the biggest one, I think. Depression. If you're depressed, you're not going to sleep. And you're not going to be able to sleep until you fix the depression. That's number one. But all the medicines that people are on. Have you seen the medicine lists that some of your colleagues are on? I mean, sometimes you need a pill for the side effects of the other pill that you're on, right? I mean, it's ridiculous. It's ridiculous. And alcohol is very, very efficient at putting you to sleep, but the problem is that alcohol is so short-acting that you go through a little mini alcohol withdrawal 3 hours later and you're up. Okay? So that's the problem with alcohol. There's other problems with alcohol too. Caffeine. Guess what caffeine does? Caffeine affects your adenosine levels. Can you see why that might make you a little bit harder to go to sleep? Okay? Especially if you have caffeine in the evening. Nicotine can do that. Blood pressure medications, decongestants, psychiatric medications, antihistamines, antidepressants during the day. All of these things can affect your ability to go to sleep. Circadian rhythm disturbances. Going to bed too early, getting up too early. So if your circadian rhythm is shifted early, and you don't realize that, then you're going to have hypersomnia from 8 o'clock till 10 o'clock at night, which is when your spouse goes to bed, and which is when you want to go to bed, or which is when you think you need to go to bed, and you're going to be very sleepy at night. And then your circadian rhythm's like, okay, we're done at 4 o'clock in the morning, and you can't sleep till you get up at 7, which is when you think you need to get up, right? And then add on to that you're awake, lying in bed from 4 o'clock in the morning till 7 o'clock in the morning, and you're saying, I can't get sleep. This isn't good. And you become frustrated. And then you associate all of those feelings and thoughts with your bedroom. Right? Then you walk into your bedroom when you want to go to sleep. And all of those thoughts and feelings come back to you, and it's performance anxiety. And that causes more insomnia. And it feeds the fire. And it's a perpetuating behavior. Do you see how that works? So there's ways to get rid of that. And then there's these primary sleep disorders. Okay. They also think about this. You guys are the perfect ones to talk about. When you guys were young, you didn't have televisions, did you? You didn't have iPads, did you? When it got dark, it was actually dark, wasn't it? So can you imagine what light does? I can tell you what light does to melatonin production. Light hitting the eye chops off melatonin production. And that actually causes your circadian rhythm to be shifted later. So imagine now you take an entire population of the United States, you give them electricity, you give them lights, you give them television, you give them iPads, you give them computers, and they're all using it until 11 o'clock at night, and they're exposing their eyes to bright light. What is that going to do to their circadian rhythm? It's going to delay it, correct? They're going to be going to bed later. Has there been any change in the time that people go to work? No. In fact, more people go to work and have to travel long distances to go to work and are stuck in traffic. So what do they have to do to get to work on time? They have to get up. What's happened to the amount of time in the United States that we have to sleep? Shrunk. Dramatically shrunk. And what do you think that's doing to people's nerves and their well-being and their quality of life? What do you think that's doing to them? Yeah, exactly. That's the problem that we have in this country. And we have to work, 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 so we can pay for the electricity that's keeping us awake. So if I were to take people with insomnia, they can't sleep, and I were to figure out, after I eliminated their medical problems, what percent is related to their sleep, this is what we would get. 35% would be due to psychiatric illness. This is why I say this is so imperative. If you have a sleep problem, specifically insomnia, and you have a psychiatric diagnosis, most commonly depression, it is imperative that you get the depression fixed, because the insomnia will not get better unless that is fixed. So we need to screen for that as physicians. 15% is psychophysiological or performance anxiety. This is what I was alluding to. Imagine having to go onto Carnegie Hall's stage and go to bed and sleep in front of 3,000 people. You couldn't do it, right? It's impossible to go to sleep if you have performance anxiety. Now, for some people, going to bed at night is like going out on stage in Carnegie Hall, because they're afraid that they're not going to be able to get the sleep that they desperately need to be healthy. And this is what they've done in their life. They've made a mountain out of a molehill and have caused anxiety. And this happens. They're in the kitchen, or they're in the family room, they're in some other room in the house, and they become tired and they feel that they're ready to go to bed. And as soon as they walk into the bedroom, where they've associated all of those feelings, they can't go to sleep. You've heard of Pavlov's dogs, right? Remember the experiment that Pavlov did with the bells? And this is exactly the same thing. So it's this psychophysiological performance anxiety. Drugs and alcohol dependency, restless leg syndrome, circadian rhythm disorders, and this paradoxical sleep disorder. These are very uncommon. We hook these people up to electrodes and we see, and they're actually sleeping just fine. They just don't think they are. Obviously, this is a diagnosis of exclusion. This is not the first diagnosis that I would come up with in somebody. So we've talked a little bit about insomnia. We can divide up the philosophy of this into the 3 Ps. There are predisposing factors, which are biological, genetic, people who like to worry. You can't change that. That's just hardwired into their body. There are precipitating factors. Similarly, this is also something that we really can't change. If something happens to you, there's nothing you can do to avoid it, right? A death in the family, a divorce, a birth. These are precipitating factors that cause you to not be able to sleep. And these things happen, right? And then there are perpetuating factors. This is something that you can do, and unfortunately we do in a way, and it causes us not to be able to sleep. This is behavioral. We're going to break that down. So this is how it looks. Here is the line above which you can't sleep. If you can go below this line, then you can sleep. So here you are in your pre-morbid condition. You're going along just fine, having great sleep, taking it for granted. And then something happens to you. A precipitating factor, that's the blue. Death in the family, divorce, marriage, baby being born, whatever it is. And now you can't sleep, okay? So you're above this threshold. Now, as the effect of that initial problem wears off, you can see it starting to come down. It will get to the point eventually where it no longer will cause you not to be able to sleep. You'll go back to sleeping just fine. Unless you institute a perpetuating factor to keep you above that line. So the question is what are those perpetuating factors? How do we identify those? And what can we do to get rid of them? And I think if we can do that, we can get you sleeping again. Does that make sense? Okay. So that's how people feel like. And let me talk a little bit about what those perpetuating factors are. We've kind of gotten a little bit onto that already. What are some of the perpetuating factors? Well, put yourself in the mind of somebody right here. Okay? After a couple of nights of not being able to sleep, what are you going to say? I need to sleep tonight. I'm going to go to bed earlier. Worst thing you could possibly do. Because is your circadian rhythm is saying that you need to go to bed at 10 o'clock and you go to bed at 8 o'clock, what do you think is going to happen between 8 and 10 o'clock? You're going to lay awake. And if you're laying awake and not being able to go to sleep, what's that going to do to your anxiety? It's going to go up. And you're going to associate that with the room that you're in, right? So now what you're doing is you're reinforcing this pattern. Okay? So you need to de-escalate. You need to say, this is fine, I'm going through a thing, this is not as bad as it is, I'm gonna be fine. Okay, what's the other thing that you could do? You could say, I need to get to sleep. I am going to watch television in bed. I'm going to read in bed. I'm going to work in bed. I'm going to pull my laptop out. Okay? Now, if you're doing that and you're sleeping fine, continue to do that. I have nothing against doing all of that activity. The people that I am talking to are the ones that are not sleeping well. Just as though you could walk into the bedroom and have this feelings of anxiety, what I want to do is do the opposite. I want you to walk into the bedroom and subconsciously think in your mind, it's time for me to go to bed. Okay? So if you walk into the bedroom, your brain has to say to you, oh, you're walking into the bedroom, it's time to go to sleep. But what happens if you're watching television in bed and eating in bed and reading in bed and doing all those things? Now your brain is saying, oh, you're walking into the bedroom. It's now time to go to sleep, or watch TV, or read a book, or, okay? So I'm only allowing you one other thing that you can do in the bedroom, okay? You can do that one other thing. That might help with sleep too, who knows? But you have two options in terms of what kind of a bedroom you want to walk into, okay? You can walk into the bedroom that you watch television in and you read a book in and you do all these things in, or you can walk into the bedroom where you've got a 50-50 chance of sleeping. And if you get the other, that's not bad either, right? Okay. All right. So these are some of the sleep hygiene things that I'm talking about, is get rid of those things. If you have a television in your bedroom, get rid of it. Now, if you are having a problem with sleeping at night and you find yourself laying awake in bed and you can't sleep, what should you do? That's right. Get up, get out of bed, go to a different part of the house. Associate your insomnia with a different room, a room where you don't need to be sleeping. Keep that bedroom as the place where you actually successfully go to sleep. Make sure you have a daily routine. Make sure that you are getting up at the same time. You're going to bed at the same time. That's going to keep your circadian rhythm on track. Okay? So it knows it's not being confused. Try to have a way of winding down at night, a winding down routine. Soft music, aromatherapy, all sorts of things. Don't exercise at night. Exercise in the morning. Exercising in the morning is very good in terms of reducing stress. Don't watch the news, okay? Especially if you're politically inclined. Don't watch some political show at night and say, oh, that fill in the blank, okay? You don't want to be thinking about that sort of stuff, okay? Don't pay bills at night. Or if you have something that's on your mind, write it down on a pad next to your bed and you say, I'm going to deal with that in the morning. I don't have to think about it right now. Okay? So these are things that you can do to avoid these things. Okay? This is after we look at all of the other things. So what is the biggest thing that I see in my sleep practice that can impede not only your ability to sleep, but also your partner's ability to sleep, husband and wife? That is obstructive sleep apnea. I think that's why a lot of you are here today, to talk about sleep apnea. So let's talk about that. There was an article that was published in The Lancet by a guy by Broadbent, where he describes a patient in his office and at home. Basically, he says here, the snoring ceased at regular intervals and the pause was so long as to excite attention and indeed alarm. How many of you have noticed this in your bedroom, either in yourself or in your partner? There's been a lot of press about this recently. Snoring can kill. You look at the wife waking up and she's seeing a skeleton next to her in bed here, okay? Discover how sleep apnea can be ruining your life. Here's a book. I love this. Exclusive, Actually Hear Deadly Snoring. So this is there's a lot of hype about this, and probably to some detriment because people say, oh, it's a bunch of hype about people wanting to make money off of some illness. I can tell you that there is some serious consequences for sleep apnea. There's no question about it. And this slide really shows the problem. The problem is really up here in the throat. And you can see here that air is going in both through the nose and the mouth, but the tongue, which is situated right here, can sometimes fall back, or even worse, other problems, and it's going to obstruct the ability for air to get down into your lungs. And so what happens is your brain is divided into two parts. There's the brain stem, which is always working, okay? It's kind of like, maybe you're too old to know The Simpsons. Remember The Simpsons? Remember Homer Simpson would go and he'd work at the nuclear power plant. He was the guy in charge of the safety and had all the buttons. Okay. So that's what's going on down here at the back. Homer Simpson is down here in the back of your brain, and he's watching the oxygen, and he's watching all of these things and making sure that they're all going fine. The upper part of the brain is what's functioning when you're awake, okay? So when you go to sleep, the top part of your brain goes to sleep. And when the top part of your brain goes to sleep, the muscles in your neck also go to sleep. So instead of being a rigid PVC pipe, they're flaccid and they're collapsible. So when you take a breath of air in through your lungs, because the lungs got the sensation to breathe from Homer Simpson, who's regulating your respirations, if this collapses, no air is going to get in. Even though your lungs want to get air in, there's no air that's going to get down there. Okay? Question. If I wore oxygen, would that help? No, because no air is getting in. Even if I had 100% oxygen, no air is getting in. Okay, so that's the issue. So what happens when no air gets in? Your oxygen levels start to go down and down, and what happens? Little red light, you die, yeah. No, because Homer Simpson is not asleep. He's in the back of your brain, and he sees the oxygen level going down, right? So then what he does is he grabs the broomstick, and he takes it and he knocks on the ceiling up above, and he wakes the guy up here in the top part of the brain that your oxygen's going down. So what does the top part of the brain have to do? It has to arouse out of its sleep in some fashion. Maybe not completely awake, but in enough fashion that it sends the nerve down to the neck muscles to open up and allow that air to go in. So it might sound like this. You're breathing normally, and then you obstruct. And then there's silence. Then Homer sends a signal down. Does that sound, how many have you heard that before? Okay. So what happens? The oxygen level goes down, Homer Simpson knocks up above, the guy upstairs wakes up enough to send the signal down, opens up again, oxygen comes back into the lungs, and oxygen level comes back up again. And then what happens when the oxygen level comes back up again? Homer Simpson's happy, guy up above is happy, everyone goes back to sleep. Cycle begins again. And this happens maybe 100 times an hour, maybe 50 times an hour, 30 times an hour. It depends on how many times an hour will determine how serious it is. And so what you have is this oxygen level going down and this oxygen level coming up. And every time this cycle occurs, guess what's released from your adrenal glands? Adrenaline. Adrenaline is released from your adrenal glands. And what effect does adrenaline have on your vasculature? It's not good. Increases the risk of stroke, increases the risk of heart attack, congestive heart failure, hypertension, all of these things. Okay? And so they have done the studies and have associated all of these things with sleep apnea. And if you treat the sleep apnea, the risk of these things goes down. That's where the real drive is here, okay? Is to reduce coronary events. Now, that's the coronary event consequence. What about your brain? How would you sleep if somebody was sitting next to your bed hitting a gong every minute? You wouldn't sleep so well, would you? That's essentially what's going on. Homer Simpson is waking you up every hour, okay? How many times an hour? We don't know. We'd have to do a sleep study to find out. So again, here's the problem. This is going back. It's causing obstruction. Obstruction. Now, see the tongue right there? Guess what, guys? When you gain weight, you, more than women do, especially premenopausal women, tend to store the fat in that tongue. So not only is the airway getting smaller, but the thing inside the airway is getting bigger. That's not good. That's going to increase your risks of having obstruction. The converse to that is, guys, when you lose weight, you lose it faster from the tongue as well. So Not to say that weight loss is the end-all for the treatment of sleep apnea, because you can have people as skinny as a rail and still have sleep apnea. Nevertheless, the tongue is a big problem, and that's why you'll see these dental devices, and we'll talk a little bit about that. Okay, so this is the definition. At least one patient complains of unintentional sleep episodes during wakefulness, daytime sleepiness, unrefreshing sleep. Patient wakes up breath holding, gasping, or choking. Bed partner reports loud snoring, breathing interruptions, or both during patient's sleep. It feels like you're being suffocated. This is from Aliens, okay? You guys remember that movie back in the 80s? Oh, never mind. Actually, it was the 90s. So you have to have a sleep study to figure if this is actually going on. What do we need to know? It's obstructive sleep apnea. We need to know if you're asleep. That's why we put wires on your head. We have to know if you're breathing. That's why we have a little thing on your nose. And we have to know if you're breathing here. Okay, so we have a little strap around your waist. Does he look happy to be there? No. Okay. The good news is that we're finding ways of doing this at home without all the wires. They're called home sleep tests, and that's the new wave. So you don't have to sleep in a sleep lab. But this is the kind of data that we get. And I'll step you through this a little bit here. This is what I do every night. I get downloaded three or four sleep studies after somebody sleeps in the lab, and they send it to me. And after I put my kids to bed, I'm exposing my eyes to bright light, and I'm going to bed later and later. Nevertheless, I am reading these sleep studies to see if we have the evidence of sleep apnea. Now, this is a French sleep study, so everything's in French, but I'll notice this. This is compressed data, and you can see here, do you see this wave here? That's your oxygen level going up and down, up and down. And you see this here? This is the movement of your chest. And the movement of the chest becomes muted here. And there's a little bit of a delayed response, so not much movement in the chest causes a decrease in the oxygen. Finally, what happens? These are brain waves. Can you see what happened right here? Finally, there's an arousal. That's Homer Simpson waking up the top part of your brain. That's what you should be doing. Well, that's not actually even good sleep there, but that's what sleep looks like. This is what being awake looks like. Can you see the difference? Those are brain waves. Pretty cool, huh? I can tell all that. And obviously, this patient has severe sleep apnea. This is what's going on every night. They're being strangled to death. Okay? So what's the treatment? The treatment is, this is a mechanical problem. And a mechanical problem, I think, should have a mechanical solution. If the problem is like a flat tire, if your airway is like a flat tire, and air cannot move through a flat tire, then the treatment would be to pump up that tire and have it remain open so that air can move back and forth. And so that is the purpose of that. So if we can inflate the tire, inflate a flat tire again, using some sort of pressure system to keep that airway open while you are sleeping, then we can avoid the obstruction. And that's exactly what CPAP is for. Now, CPAP stands for continuous positive airway pressure. That's exactly what we're talking about. You understand now why that would work. It's because we're trying to put an airway of pressure in there just enough to stent that airway open so that it won't collapse. Okay? CPAP is the oldest treatment for sleep apnea. It is the most studied, and it is the most effective. Okay? Any other treatment for sleep apnea is because someone doesn't tolerate CPAP. The compliance rate is about 60 to 70%. That's a significant amount of people that can't tolerate CPAP. So, but in terms of its efficacy, we can titrate it so that it's perfect and that you don't have any sleep apneas. So there's different types of masks. There's ones that fit over the full face, that includes the nose and the mouth. We always must include the nose, okay? So nose and mouth. Then there's ones that fit over just the nose. These work really well if people are good at keeping their mouth closed, okay? So we ask them, do they gossip a lot? If they gossip a lot, we go to no, I'm just kidding. So physically, they've got to be able to keep their mouth closed. And obviously, you know the reason why, right? Because you can't pump up a tire if there's two holes in it, and only one of them is patched. So if we put air in through the nose and it comes right out the mouth, it's not going to go down here where it's needed. So sometimes we'll actually give them a chin strap. Here's some other examples. This is called the nasal pillows. So instead of fitting over the nose and causing maybe an abrasion on the nose over long-term wear, it actually fits into the nose and we can anchor it on the teeth, on the teeth or on the face. Okay, those are nasal pillows. So sometimes we need to use a chin strap to keep the mouth closed. And you can see here are some examples of that. Here's what CPAP machines look like. Some of you have newer ones. This is kind of an older one. Almost all CPAP machines, in fact, I would say all of them now come with heated humidification. That is just a necessity because not having humidification makes things very uncomfortable, and you'll improve compliance if you have heated humidification. In terms of how loud they are, I'm worried about this CPAP machine. It's so loud. They're becoming softer and softer and quieter. They now range around 26 to 30 decibels. Okay, that's half that of the buzz of a mosquito. Here's a sleep study from overnight. What we typically do is we do a split night study. So we split the night into two groups. Now check this out. Here we're looking at their oxygen saturation. What does that look like? That looks like the San Andreas Fault because it's going up and down, up and down. Each one of those Homer Simpson wake-ups is one spike. Can you see how many times they're getting up and waking up? They don't even realize that that's happening. It's all happening subconsciously. And we mark each one of these episodes with a little line down here. You can see there's so many lines that they're just running together. These are OSAs and these are hypopneas. So this is where they completely stop breathing, and this is where they almost completely stop breathing. And you can see here there's stages of sleep. Remember that graph I showed you at the very beginning showing where they are sleeping? And so you can see here that here they're sleeping, they go to bed, arousal, and then they wake up. Now we put them on CPAP. And notice we start out at a pretty low level. So we started off at the lowest level possible, and we just have them sleep with that. And through the night, there's a respiratory tech there that's watching them. Okay, I know, how hard is it to go to sleep when there's someone watching you, right? They're actually watching you in the back room, and they're not really watching you, they're watching the data that's coming through. And they see, well, we've gotten rid of a lot of the apneas, but there's still a few of these hypopneas, which are almost stop breathing. Let's continue to ramp up the pressure. And the goal here is to ramp up the pressure enough so that we eliminate the apneas. And that's exactly what we do. Finally get to a final pressure before the end of the night. Notice that they went into REM sleep here. Here at this REM sleep, notice something that's really interesting here. Here's the REM sleep, right? Notice what happened when they went into REM sleep. They had a few more apneas. So the pressure was not enough. That's why we keep going up on the pressure. Finally, we get up to a pressure where they go into REM sleep and they have no more desaturations. There's one or two little ones there, but that's okay. You can have up to 5 an hour and still be normal. This is what's going on every day of this person's life. This is what their new life is going to look like on CPAP. Here's another example, and another example. There, we went right to 10. Look at that REM sleep. Sometimes they get out of there and they're like, wow, I've never slept like that. And I have some patients that would shoot me if I told them they had to go on CPAP. And I have some patients that would shoot me if I took away their CPAP because they just will not live without it. So here's what we call in terms of the apnea-hypopnea index. I don't want to get too much into the details, but obviously the more times you stop breathing, the more severe it is. In terms of men, about 24% of them have an AHI of 5 per hour. That means that they stop breathing 5 times every hour. You can stop breathing up to 5 times an hour, and that's normal. That's okay. Women is about 9%, but let me tell you, women catch up to men very quickly after menopause. Okay, they catch up. So this is not a male-only disease. And we notice that HRT reduces the risk, but let me tell you, HRT is not great because what does hormone replacement therapy also do? It increases the risk of stroke independently. Okay? Risk factors, obesity. You know, if you lose weight, your AHI goes down. Your risk of sleep apnea goes down. Also race. Non-whites typically have a higher incidence of sleep apnea, because it's not only weight, but it's also facial structure and nose and palate. And some of those things are genetic. You know, if you have a first-degree relative who has sleep apnea, that increases your risk substantially. So there's genetics that are involved as well. Nasal obstruction as well. Age. As you increase in age, up to the age of 65, it increases. After the age of 65, we see the prevalence just sort of plateau. We don't know if that's because those people are just dropping off the face of the earth, but it seems to plateau. Maybe it's kind of, I don't know, survival of the fittest. Interestingly, hypothyroidism doesn't seem to have a connection, and menopause is known as the great equalizer for women in terms of sleep apnea. So what happens if you don't wear it? So what are the consequences of obstructive sleep apnea? We talked about this. Daytime sleepiness, neurocognitive functioning. So where did I leave the keys? I can't think straight, I can't concentrate. That's because you can't sleep, right? Okay, so you got to be able to sleep. Mood disorders, depression, decreased quality of life, hypertension, diabetes, stroke, cardiovascular, motor vehicle accidents. All of these things can be associated with sleep apnea. So CPAP therapy, as I said, it's first-line therapy for OSA, reduces blood pressure by 10 millimeters on average, improves or resolves daytime sleepiness, does great. Compliance we talked about, 5 to 7 nights per week for about 4.5 hours is deemed as compliance. We talked about humidification, working on the right fit. Other things that you can do, weight loss, even a 10% reduction. Check your BMI. Have your BMI measured. Okay, if you don't know how to calculate it, there's calculators online. If your BMI is over 25, you should lose weight, and you might notice an improvement. If you don't solve your obstructive sleep apnea problem, you may reduce the pressure that is necessary to treat it. Okay? All right. Smoking can cause inflammation in the airways, and that's just going to shrink that area more. Alcohol reduction. Okay, so alcohol. What is alcohol's effect on sleep apnea? If you think about giving Homer Simpson a drink of alcohol, that's exactly what it's going to do. The guy who's looking out for you, who's watching your oxygen, if he's not on the job, that oxygen level is going to go down for longer, and you're going to have a more delayed recovery. So alcohol is not good therapy, and this also goes along with sleeping pills with sleep apnea, okay? Because it's your bottom of the brain job, the responsibility of that to wake you up. And if it's under the influence of Ambien or these sleeping pills, that's not a good thing. So non-CPAP therapy, oral appliances, there's two types. There's the jaw advancers, and then there's the tongue suckers, okay? So you've seen these type of things. What's the purpose of this? The purpose of this is to advance the jaw forward, and because the tongue is anchored to the bottom of the jaw, if I can advance the jaw forward, then I can advance the tongue forward. The whole point of this is to advance the tongue off the back of your throat. Okay? That's the whole purpose of this. The problem is that if you don't have all your teeth, you can't do it. Okay? The nice thing is that this is a lot easier to tolerate than CPAP in some cases. So in some cases we would go with this. It doesn't work so well for people with very severe sleep apnea. Okay? And also it can cause TMJ problems. That's the biggest problem for that. And then when you wake up in the morning, sometimes you feel like, let me chew some gum to get my jaw back into place. Okay? It's also a lot easier to carry this on a plane than a CPAP machine. So there's advantages and disadvantages. I think this is another tool in the tool shed for the job that needs to be done. Be careful of some of these boil and bite things that you get on the internet. Okay? They don't fit the teeth very well, and they really don't work as well. So just be careful of that. I would go see a dentist who's trained in sleep medicine if you're going to get one of these things. This is a tongue sucker. Okay? So you stick your tongue in there, and it sucks onto it, and then these little things right here, you pull it out, and you stick it on, so it locks onto the outside. So basically it grabs your tongue and pulls it forward. Okay? Some other things. There are some evidence that this works. Notice here that our goal in CPAP is to get your AHI less than 5. because 5 is normal. What they find in these devices is that they can't get the AHI down as low. So 1 for 1, the CPAP is more effective than the dental device. CPAP more effective than the dental device. Their argument, when I say their argument, the dentist's argument is, well, these are actually a lot more easier to tolerate, so our compliance rates are better. So population-wise, it may be the same efficacious, but on a per-patient situation, if I can get you to wear a CPAP machine rather than a dental device, I think I can do a better job at getting your AHI back to normal. Does that make sense? Okay. Some of the surgeries, this thing called a UPPP used to be very, very popular 10 or 15 years ago. The ear, nose, and throat surgeons were basically cutting that little punching bag at the back of your throat out, and the soft part of your palate back there, they were opening that up, thinking that that was the problem. Ever chew something and swallow it and have it come out your nose? It doesn't happen because you've got the soft palate there. Sometimes that happens when you don't have the soft palate. And once the surgeon takes that soft palate out, it ain't coming back. So, yeah, this sometimes works. Didn't work as well as we thought it would. There are other things that we can do. There's implants, there's bariatric surgery to lose weight. There's even like irradiating the back of your throat to reduce the amount of tissue back there. None of this has really worked well. There's medications. Modafinil is a medicine that's not really for sleep apnea. It's for people who have excessive sleepiness despite the fact that their sleep apnea has been treated. And this kind of wakes you up a little bit in the morning, but it's by prescription. So, summary. OSA is a danger lurking in each bedroom. It's like a shark. Diagnosis rests on the overnight study. CPAP is the first-line choice. However, now the FDA has actually approved dental devices as first-line therapy in mild and moderate sleep apnea. What does that mean? That means you no longer have to show for the FDA that you failed CPAP therapy to go right to a dental device. Okay? So that is new. Behavioral changes, use of oral appliances, digging into the details in patients, and that's what a whole clinic visit is for. Otherwise, we could just, put the whole planet on CPAP, right? So actually talking to people, figuring out what their problems are, why they can't tolerate things, and tailoring the therapy for that individual is really where the key is, and education is key. I talk a little bit about CPAP. I equate obstructive sleep apnea and CPAP to, this is OSA, okay? You're in your stateroom. The ship is going down, and you have a choice. You either stay on the ship, or you go into your little dinghy boat here called CPAP, or you could stay in the stateroom where there's no CPAP. Okay. There's other options now. There's many different types of lifeboats. Let's really quickly talk about restless leg syndrome, medication, narcolepsy. These are very quick slides. Do you have restless leg syndrome? You see these medications advertised on television for restless leg syndrome? Okay. Do you have it? You should use this mnemonic, urge. If you have these symptoms, then you probably have restless leg syndrome. Do you have the urge to move your legs as you go to bed? Does rest make it worse? So when you pop into bed and you're just sitting there, does that make it worse? Does getting up make it better? So when you walk around, does that seem to make it better? And is it worse in the evening? Okay, this is not pain, this is not burning, that's not restless leg syndrome. We see that about 20% of the population, age 50 to 80, have this. It's more common in women, especially if women who've had multiple kids. We don't know exactly why, but we think it's related to iron deficiency. And this is an important distinction because if you go to your doctor and have your iron levels checked, they'll check something called ferritin. Ferritin. The lab will publish a normal value for ferritin, and the value is 20. So if you go to the doctor and they check your ferritin level and it's 30, he'll say, oh, you're fine. But if you say that you've got restless leg syndrome, the recommendation is that that ferritin level should not be anywhere close to 20 or 30. It should be above 50. So that's something that's important that you should tell them. We find that in women, especially, if you get your ferritin levels checked, your iron levels checked, and your ferritin level is below 50, and you have symptoms of restless leg syndrome, and we give you iron supplementation to get it above 50, even though that's not the published normal value, we find that a lot of these symptoms go away, and you don't need medicine. Okay? There is a couple of medicines out there like Requip. If you've ever read the package insert for Requip, there's a couple of interesting side effects. I don't know if you're aware of this, but apparently impulse control are one of those things that you lose when you're on Requip, potentially. So, blowing your earnings in Vegas in a weekend, okay? Or I won't get into some of the other things that have happened that this company has been sued for successfully, but anyway, so you've got to make sure that if you're on that medicine, you know that you could just lose all impulse control and do a whole bunch of crazy things. It's a perfect lawyer's medication, isn't it? Anyway, you can avoid getting on that medicine to making sure that your iron levels are checked. So here we go. So this is what it says. Several unusual adverse effects may include compulsive gambling, hypersexuality, overeating, even in patients without any prior history of these behaviors. Other compulsive behaviors such as excessive shopping and even cross-dressing have been reported. I don't gamble, but I've gone to some local casinos, and I never see these people in there. Anyway. Okay, let's talk about medication. Medications affect a lot of you. I think we see here that 90% of Americans over the age of 65 take some sort of prescription medication. And so aging changes absorption of these medications in terms of absorption, distribution, metabolism, elimination. And there are medicines that can affect sleep, like, for instance, in insomnia, decongestants, theophylline, methylphenidate, amphetamines, not even just in elderly, but in everybody. Benzodiazepines, this is like Valium, Xanax, Ativan, can cause depression. Reglan, antipsychotics can cause Parkinson's disease. There are a lot of medications, just high blood pressure medications, beta blockers, ACE inhibitors, like anything that ends in an olol. A lot of these medications are now going through a system, your system, that doesn't clear them as well, maybe absorbs them differently. And so it's very important that if you're having problems with sleep, that you look at your medication list and look at the side effects. I know you guys do a very good job of that, because I get patients back all the time. Doctor, did you know that this medicine could cause this? Yes, I know that. But it's very rare, and anyway, so look at these medications, look at your medications, and it's very possible that your sleep problem could be an effect of one of those medicines. Finally, narcolepsy, which I know none of you have because this is a disease of the young. The reason why I put that on there is because it's a very complicated disease. These are people who fall asleep very quickly, and the most classical symptom associated with narcolepsy is they lose strength on emotion. So if you crack a joke at a party and they start laughing, or if they're really mad, they'll just collapse to the ground. They won't just fall asleep like that, as you see on television. Sometimes they make fun of narcoleptics. They're talking like this, and all of a sudden they're sleeping. It's not really actually that way. None of you would have it. It's generally in the younger population. I throw it up there just because it rounds out all of the topics that we've talked about today in terms of sleep disorders. The treatment is the sodium oxybate and modafinil. Remember modafinil? That was the medicine that we used in sleep apnea. If people who were not getting restful sleep despite the use of CPAP, this is a medicine here that will wake them up. So we give it in the morning, not in the evening. And there are two forms of it. There's the mixture, and then there's the sort of the pure enantiomer modafinil, which we give as well. So in summary today, we found out that aging is associated with sleep disturbances, but aging per se may not be the cause of sleep problems in older people. Insomnia has many causes and therefore many fixes. There are, however, some basic things that can be done to improve your sleep. Obstructive sleep apnea is insidious and can lead to serious consequences. CPAP is effective at treating and can improve sleepiness and quality of life. Restless leg syndrome is very common and frustrating, and there are treatment options available. And medications can be a major cause of sleep disorders and should be carefully reviewed with knowledgeable physicians to avoid pitfalls. Finally, narcolepsy is a rare but distinctive disease that should be recognized as there is good treatment. And I want to thank you at this point and open the floor to any questions. Yes?
What's your thoughts on taking melatonin to help you sleep?
Yeah, melatonin's great. Melatonin is, however, the problem with melatonin is that not melatonin itself, it's how you buy it. It's not an FDA-regulated drug, because it's not a drug, it's actually a natural substance. Your body makes it. So anything you buy over the counter, you don't know how much is actually really melatonin. The effect of melatonin is going to be the opposite of light at night. Light exposure to the eye is going to delay the onset of your circadian rhythm. Melatonin is going to do the opposite. It's going to advance it. So if you take it about half an hour before you want to go to sleep, it's going to help in terms of having you go to sleep. The irony is that the smaller the dosage, the more effective it is, up to a point. So 2-3 milligrams, no more than 5 milligrams. If you take more than that, it's not going to have that effect, and it's just going to make you really irritated. Not because you can't sleep, but it actually just physically makes you irritable. Yeah, people take it on a daily basis. It's a natural substance, but just be aware that it's going to advance your circadian rhythm. So you want to take it at the same time every night, and you want to take a relatively low dose.
What about over-the-counter medication like Advil PM?
Advil PM. Advil is an anti-inflammatory. The PM part of it, I'm assuming, has a little bit of Benadryl in it. I'm not exactly sure. If it's anything that's going to make you sleepy, and all the medicines on the over-the-counter stuff right now that you can get, it's either Benadryl, some antihistamine. It's not a narcotic if it's over-the-counter. Those are probably not good for you at your age, and I'll tell you the reason why. Benadryl has anticholinergic effects. Antihistamines have anticholinergic effects. What does that mean? It works against the neurotransmitter called acetylcholine. Acetylcholine is the neurotransmitter that helps you think. And this is the same neurotransmitter that is reduced in Alzheimer's disease. In fact, a lot of the Alzheimer medications that are used boost acetylcholine. Okay? So you can see why that we wouldn't want to do anything in that population that reduces acetylcholine.
Better to take melatonin then?
I think so. And you don't need a prescription for it. Yes?
After having a sleep study and being diagnosed with apnea and being put on a CPAP machine, is it then advantageous to have a second sleep study to determine if your CPAP machine is working for you?
Good question. So what we want to have is we want to have data, material, sleep study that shows that you on the pressure that you are on eliminates the apneas. And that can happen in a number of ways now, at this point. It may not have been when you had it, but this is the way we can do it. We can have it where we do a split night study that we talked about before, and it showed that the CPAP was going up. So that would show that you, on that pressure, eliminated your apneas. So that's one way of doing it. So it's possible that if you had a split night study where they put the CPAP machine on you for that study, and then you left, someone reviewed that data, said that you on this CPAP level eliminated your sleep apnea, then you do not need to have another study unless you changed your weight by more than 10%, or there's been a change in your clinical symptoms, or there's been a change anatomically.
So are you saying that an initial sleep apnea test actually used a CPAP?
There's two ways. Sometimes you can have a sleep test where they never got to the CPAP portion. And if that's the case, then what they would need to do is they would need to do another test, and there's a couple of different ways of doing it now. So the way that it used to be is you would have to go back into the same lab. They would then use the whole night dedicated to just putting a CPAP machine on you and adjusting it so they saw they got the right pressure. There are two other ways of doing it. The other way of doing it is doing something called an auto CPAP machine. And if they do an auto CPAP machine, they would never need to do another study. And let me explain what that is. A regular CPAP machine, you have to dial in the number, and it stays at that number. An auto CPAP machine actually can tell when you're having obstructions and will automatically increase its own pressure on its own. And so what that does is, let's say that your sleep apnea is worse when you're on your back, and it's not so bad when you're on your side. So if you're wearing the machine and you're sleeping on your side, maybe the sleep apnea machine checks that and says, oh, I only need to be at a pressure of 5. And then let's say you move on your back and says, whoa, and it ramps it up to 10. So it's thinking during the night for you, depending on the position that you're in. For that, we'll never need to have to do a study, because if we give you an auto CPAP, it's going to adjust itself 100% of the time. So in that situation, what insurance companies have done is they're willing to pay the higher price for the auto CPAP machine, which obviously costs more money than a regular CPAP machine. And they'll do that because they don't have to pay for another study. Does that make sense?
Yeah, I understand perfectly what you said. What I don't know is how to go about finding out what I need to do.
Go to your primary care physician and have him refer you to a sleep specialist if he can't figure it out, and have him pull up the old study. If that study was a PSG only, then you've never had data that shows you on CPAP. If it's a split night study, which means that they did CPAP at the end of it, then they should have that data. If it's been more than 5 years old, or you've changed weight, or you've noticed, then you may just need to have another titration. They call it a titration.
Is it advantageous to wear your CPAP machine if you're napping in the afternoon?
Absolutely. Anytime you're asleep, you should be on a CPAP machine.